As a retinal specialist, I'll be managing a lot of patients who have disease outside of the macula and often in the retinal periphery. And we know these don't image very well with traditional 40 to 50 degree photography. So ultra-wide field allows us to assess and make diagnosis of these peripheral conditions more accurately. At the same time, as the director of our reading center and teleophthalmology service, I'm very well aware of the limitations that we have with retinal photographic screening, and having a wide field or an ultra-wide field device available will enable you to pick up more disease and more accurately grade the diabetic eye disease. In most telemedicine screening programs, we often have to rely on non-physician graders to grade our retinopathy images. Accurate grading is especially critical, and it really is enabled by having images that appear in the true color. That means that your graders, your physicians themselves, will be able to interpret these images with the same amount of accuracy and reliability without a significant amount of retraining. There is active proliferative diabetic retinopathy, as you can see on the wide field image, with pre-retinal hemorrhages that was missed on the physician examination. In this case, if you had used a traditional 45-degree camera, you would have missed all this pathology in the periphery. This is where the Clarus really helps in making more accurate diagnosis, and in this patient it would have been critical. If these lesions demonstrating pre-retinal hemorrhages were not detected, the patient would have been sent back for screening or brought back in a 6-month or further appointment for review. In the case, because we picked up the PDR, he received treatment. We do know from the review of our own data that when patients have retina images taken with an ultra-wide field image, about 8% get regraded as having vision-threatening diabetic retinopathy or worse, as compared with the traditional 45-degree fundus camera. And so these 8% of patients would receive appropriate treatment, which would have been missed if you did not have an ultra-wide field image available.
I am the retina and uveitis specialist, so today I'm gonna show you what Clarius 500 changed our practice in the daily life practice. With Clarius 500, you can take the whole picture of the lesion and you can use it to follow up. And again, it comes together with the autofluorescence that help us for diagnosis and also use it to follow this patient. This is another case of azure or acute zonal occult outer retinitis. With the conventional fundus photography, you're gonna have like 45 degrees. But with one shot of Clarius 500, you get the 133 degree true color. It's very quick, you're gonna get more detail and even more with the montages picture.
As a busy retinal specialist, ultra-wide field imaging allows an efficient, reliable modality to capture high-resolution images of the posterior pole and the periphery. In the current era of multimodal imaging, ultra-wide field imaging can also be correlated with other modalities such as optical coherence tomography and angiography to accurately diagnose, monitor disease progression, and look for response to therapy. In this first case example, in the presence of a significant cataract and medial opacity, a traditional 45-degree color fundus photo is unable to capture the posterior pole details with such great resolution. However, with the wide field Clarius image, you can see with a 2-image montage, a wide area of the fundus can be captured, and you are able to appreciate the vascular changes and the peripheral disease of dot and blot hemorrhages in this eye with proliferative diabetic retinopathy, as well as areas of neovascularization. Here you can see areas of flow voids and neovascularization, and this patient is receiving anti-VEGF therapy for her proliferative diabetic retinopathy, and we are able to use consecutive wide field imaging coupled with OCTA to monitor her response to treatment. The ultra-wide field Clarius image captures the whole extent of the vitreous hemorrhage as well as has good enough resolution to capture the area of neovascularization confirmed on the fundus fluorescein angiography. Correlating this with optical coherence tomography angiography in the Plex Elite, on the on-fast image you can see this area of neovascularization is also seen on the cross-sectional OCTA, and it is an area of vessels that actually emerge from the retinal surface, confirming the presence of neovascularization. You can see the 55-degree multicolor image only shows partially the extent of this BRVO. You can see that this branch retinal vein occlusion extends to the periphery and much more of the extent is seen. This correlated to the OCTA. You can see that there is areas of flow void both in the superficial as well as the deep plexi. Using a fundus fluorescein angiography, we require a 4-field montage of the fluorescein to adequately capture the same area of ischemia that we can see on the OCTA. The Clarus wide field image shows very clearly the areas of sclerosed vessels and ischemia. This can be correlated with the OCTA. The areas of flow void are both present in both the superficial plexi as well as the deep plexi. This is also correlated with the wide field fluorescein angiography. In this case, we are clearly able to see with good resolution that the foveal avascular zone is intact and not involved, and the patient has a good visual acuity of 6-7.5.
Ultra-wide-field imaging has revolutionized the fundus examination in ophthalmology. It has become an essential tool for the identification of peripheral retina and vascular pathology. The high resolution and multimodal capabilities of Clarus are also providing new insight into a variety of disorders, even those that primarily involve the posterior pole, making it well suited to enhancing the efficiency, quality of ophthalmic care and increasing the patient satisfaction in our practice. The use of advanced technology such as Clarus fundus imaging system provide more useful clinical information, whereby for this patient with retinal tear, round hole with operculum, even with previous laser treatment done, I might have to consider top-up laser treatment for the new inferior temporal tear. The 200-degree ultra-wide-field image of male 56 years old show the extent of retinal detachment and retinal tear supratemporal, very clear from macula to peripheral area, and I can associate with the visual field loss in this patient.
Singapore Chunghwa Medical Institution mainly serves the aged population, and the average age of the patients is from 55 years old to 85 years old. And I think Clarius 500 helped us to detect many pathologies in the aged population. There's one case of the 26-year-old male I remember, and we accidentally picked up that he has 2 retinal tear at the very far out peripheral zone in the retina. And I think under this normal fundus camera, we are unable to pick this up. I think we are lucky to see this, and then we refer him to the emergency cases. There's one 59-year-old diabetic patient came in, and we noticed that under the Clarius 500, the leaking vessels far zone like temporal side and the nasal zone are very, very clearly seen. Of course, his case with also glaucoma and central CME, cystoid macular edema, can be picked up by the normal fundus camera. But the leaking vessels far away, like in the temporal side or in the nasal side, definitely cannot be picked up by the normal fundus camera.